Friends, for this module on ERCP, we are going to show you two cases of ERCP going to happen. Before we understand as a basic endoscopy course trainee, we need to understand something on the ERCP, which I'll present in the next 5 to 6 minutes on a background knowledge. Once you know that, then we'll go and see a patient where all the steps are carried out the way we are going to describe now, followed by another case to emphasize the same thing which we learned. So that is the aim of this particular module. Let me take you through this particular thing. That is, here, unlike the conventional upper GI endoscopy, here we are going to use a scope which is having an objective lens on its side. That is called a side viewing duodenoscopy. There are special accessories are required, and also we should know when ERCP is indicated, because no longer we do ERCP as a diagnostic procedure. For that we have another procedure known as MRCP. So it's purely therapeutic with a clear-cut indication, because ERCP, if it is not performed well, it can lead into life-threatening complications, commonest being a pancreatitis. Then let me just take you, this particular patient which you are going to see in the next few minutes is a case posted with lap chole followed by ERCP, that I call a single stage sequential procedure. So two procedure, we are going to do it together, and we have just performed the lap chole and we are going to do ERCP. Why we do ERCP? Because he presented with the abnormal LFT with the SGOT, SGPT, alkaline phosphatase, everything is high, and also the ultrasound showing a dilated CBD. But the sensitivity and specificity of the ultrasound to pick up the stone in the bile duct is not good. So sometimes you may have to do an MRCP, or if suspicion is strong enough, as in this case, we will be doing a ERCP straight away. For that, these are the steps of procedure as you can hear. First, ERCP, it's like a teamwork. So as I said just now, we would love to do an MRCP, but that is purely diagnostic. Endo ultrasound can be also done, but it is only in few centers they do. So here is an MRCP of a patient where you can see very easily a dilated system with a stone here. That is a test of choice. I am not controversial on that factor, but what is important is here in this particular case there is a strong indication, because she is having a slight dilated CBD, okay, and also slightly abnormal LFT. So there is a high risk, there is a 50% chance we are going to see a stone here. So I am going straight for ERCP. But pre-operatively, if you think the patient is only having a moderate risk, like a recent history of pancreatitis, those conditions, one may say, why don't you just go MRCP? If it shows some suspicion, again, then you may proceed, because I am repeatedly telling you ERCP sometimes can be lethal because of the risk of perforation and pancreatitis. So this is what we have just done in this patient. Instead of what we call the conventional twin session, that is, do ERCP few days before, then go for a lap chole. Here we are going for a single session, intraoperative ERCP and lap chole. This is what we have done. There are other competitors for the same technique which I am just describing now. One, of course, is for a laparoscopic surgeon. He can explore the CBD also laparoscopically. That is perfectly all right, alternative to what I am just going to explain. And the next two, one is a conventional surgeon, that is old styled open exploration of CBD after open cholecystectomy. So these are all perfectly feasible. In this particular patient, just now we end up performing a lap chole. Now we are moving into ERCP. Hopefully it should be okay. And this is the in position. As you can see, we can put the patient either on a supine or a prone. Today we are going to have a prone patient, because that is for a beginner, it is quite a comfortable position. And it needs, like ERCP is a 4-letter word, it needs 4 people. One, of course, is me, the anesthetist, patient general anesthesia, because the high aerosol generating procedure. Moreover, the patient is very comfortable, and you will be able to have a high successful cannulation rate in a general anesthesia patient. And of course, your staff and also a radiographer with a C-arm. And this is the side viewing scope we are going to use, and these are the accessories. As you can see here, we will be going and reaching and docking in the facing the ampulla waiter in the second part. Then I'll ask my staff nurse to give me what we call a sphincterotomy, then cannulate, what we call a selective cannulation of the bile duct. Then we will move on to, depending upon what we find, then we will open or lance the sphincter and then open it and necessary dilate it. Then by using what we call a Fogarty biliary balloon, we remove the stone, do a check cholangiogram to make sure everything is clean. If necessary or if there is evidence of any sepsis, then we will probably put a stent in. Occasionally, there may be difficulty of cannulation. For that, we have a plan B, that is by using what we call a pre-cut sphincterotome. So those equipments are ready, and I will just show for a beginner, this is what the layout. Sometimes the initial intubation is preferably done with a patient in the left lateral position, or what we call a semi-prone position. Because here it is a side viewing scope, the view as you travel down through the esophagus on through the stomach is not optimum. But you can go through the and D1, D2 junctions. You have to do some maneuvers and go and dock right in front of the ampulla. We are going to show all these things in the live. Selectively, you just take the sphincterotome, cannulate the biliary duct, which is up onto this left here around 10 o'clock position. This is pancreatic duct. So you have to go selectively. So the art of that is selectively getting into the bile duct, this is what takes a lot of learning to do. So we'll tell you some tricks to enter and then inject contrast, identify the problem accordingly. You can manage. If it is a small stone, if it is going to come by just enlarging the opening, then I can just take a radiological imaging, like what we call a fluoroscopy like this, identify this filling defect, then I pass over the guide wire, either a balloon or a Dormia basket. Before that, we enlarge this hole by what we call a sphincterotomy by a monopolar current. That is what I call endocut. Then see, this is the balloon coming and inflate, and it will very easily. You see how simple the procedure, how least traumatic the procedure is going to be, provided you know exactly what you are doing. Okay, and if there is any suspicion of malignancy, there are ways to take a biopsy also, or cytology also, cytology breast and things like that. Okay, so if there is a stricture in the pancreatic and biliary tract, then either you can go and drain the area with the stent also. So this is what we are going to do. These are the steps we are going to demonstrate. We will be removing the stone, hopefully in this lady, either with a balloon or a Dormia. And a successful outcome is something like this. A stone, you are able to see, patient is relieved of her pain and problem. And this is a nutshell ampulla, periampullary diverticulum. This is sphincterotome, dividing with the bow wire with the electric current, cutting like an endocut at around 10 o'clock position. This is at 10 o'clock, so that least amount of bleeding. Once you are able to do that, then you will be able to take the stone. Occasionally, sometimes you do a special procedure, especially in a patient with a large stone, a stone more than 1 centimeter or 1.2 centimeter, wherein if the duct is big enough, then you can put what we call a CRE balloon. Yeah? So this is a controlled radial expansion balloon, which as it goes in, it will dilate the lower sphincter to such an extent. So even a stone right up to 1.2 to 1.5 centimeter, without a need to crush it, it can be grabbed or dragged down into the duodenum. So this is the thing. But the most important thing, you need to have a good diathermy in order to do that. And there are settings already there, what I call endocut mode for ERCP. So what is the advantage of endocut mode is, when you put the push pedal on the yellow button, it won't cut like a zipper. It will cut, pass, cut, pass like that. So chance of what we call a zipper effect or causing a undue bleeding is much less. That is the requirement if you are going to do under surgery. So in essence, even though MRCP is the investigation of choice, here we chose ERCP as a treatment of choice because it is not only diagnostic but also therapeutic. So you can see
absolutely
the objective lens and the eyes are there. In addition, you can see something is moving up and down. That is what I call the elevator controlled by your thumb. So in addition to the big wheel, small wheel, you have one more thing you allocate for your thumb. That is the one difference. Okay. The second important thing is, of course, the channel is 4.2 millimeters, fairly big one. So even a stent of 10 or 11 French can easily go in. So this is ideal therapeutic scope. If a patient is
Correct.
having some difficulty intubating or pediatric, we have a smaller size scope also available where the channel is only 3.2 millimeter. That's about
Right.
the scope I need to tell you. The next important thing is, as
Right.
you can see, a panoramic view of my theater, the patient, my staff in the head end is there, another staff is helping me with accessories, anesthetist is intubated, because I find lately intubating the patient is keeping me also peaceful, patient also is comfortable, and cannulation rate is better. So that's my take home message for all. And there is, otherwise you will be giving a propofol infusion, constantly monitoring the patient. But so I am for doing everything in the last 2-3 years GA. That is another small change. I deviate from the gastroenterologist. The next important thing
Right.
is, if you can come here, I am going to show you the table in which we have arranged 2 essential equipment I would require in this case. Of course, cannulation by a sphincterotome, and of course a balloon to remove or sweep the stone. These are the 2 things. As
Right.
we go in, I'll explain. So let us go for a
Right.
intubation. So the patient is in a prone. There is one more person I'm asking him just to take the shoulder, making the patient semi-prone if possible, like this. If it is done,
Yeah, in the
then
lateral.
intubation is
lateral
slightly
position.
easy.
Okay. Okay.
And you can easily go into the esophagus. And if you watch my hand and the big wheel, if you keep it a little away from you, you may have a little, you can see the esophageal wall. Otherwise, you are only
Right.
seeing the side. And as you go in around 40 centimeter, you just torque the scope like this. Okay? Then you will go along the greater curvature
Right.
in the long route. And you will
Okay.
be, until you reach and see the pylorus, he has to maintain this position. That is the secret. And sometimes bile will show that you are nearing that area. So you can see here some antrum, the converging mucosa, and presence of little bile. It will tell I am just nearing. You bring the pylorus, what we call a sun setting position in the long route. So this is what I am doing. I am already done that. This is the pylorus disappearing under me. This is the first part, second part duodenum. Once I enter the second part, I just have small wheel, big wheel, then small wheel away from me, that is, then lock it, then go further in like this,
Right.
then
Right.
go beyond
Right.
that ampulla, then big wheel also towards me, lock it, then try to shorten and also turn your body like this. So when I do that way, then you usually stay at the junction of the second and third part. And if there is any lot of
Right.
bile, because what I did in this particular case is, I was just squeezing the bile duct as we were doing dissecting the gallbladder. If there is any stone, it will come out. So that's why a lot of bile than not normally what you see. I'm just at the junction of the second and third part. I have to come back. Now is the time for my radiographer to come in. So raise the table, keep patient.
So I have a question.
Yes,
Sir.
Jaydeep, yes, fire away.
So pre-operatively, what was the imaging suggesting?
See, this patient had an ultrasound that showed a bile duct of 8 millimeter.
Okay.
There is no obvious stone. SGOT,
Right.
SGPT both above 200, alkaline phosphatase
Okay.
300, gamma GT 500.
All right.
So the debate is whether you do MRCP, then go for ERCP, perfectly right, nobody will question. Or if you have EUS, you do EUS and then go. I chose this already because the likelihood of, because this patient has been waiting because of the COVID for nearly 2 weeks without relief of pain, persisting pain. The LFT remained, actually LFT increased. There is only difference is no bilirubin. Bilirubin is normal.
Okay.
So
Right,
I have a
right.
gut feeling this patient can save money on this MRCP, which is purely diagnostic. We can go. That is the only thing.
Right.
Okay.
Okay.
This is what
All right. Okay.
what we preach. Maybe slightly different from what I practice because of the cost implications. See now, I am just. Can you see now the ampulla is staring at you?
Sorry?
A endoscopy view. I'm just. What you are seeing is a very small ampulla, and that is right at the middle.
Right, right.
Can you see it now?
Okay.
Yeah. And
Yes, yes, yes.
So in other words, this is the only longitudinal fold in the midst of the horizontal fold. If you trace the longitudinal fold from 6 o'clock in the monitor, it will end up with a slit-like opening and with a bile coming. See, you can say it is opening momentarily.
Yeah, you can see the bile gushing out little.
Yeah, this you can even see the some little peristalsis. But this is actually the opening itself is slightly facing away from me. So we need to be very, very careful. See, there are some stones also came as we speak, some gravels, I won't say stone. So because of all the manipulation we did during the lab quali, sometimes you dislodge a stone also, milk the stone out. So what I'm doing is through the
sludge probably also.
Yeah, through the access channel, I'm passing the sphincteratome now. So I've just passed the sphincteratome now. You will be any minute, you will be seeing the sphincteratome. And you will be able to understand the mechanism as we go inside and show it in the monitor. So this is the Boston Scientific microvasive sphincteratome, which is there. The ideal position where you want the ampulla is somewhere around 10 o'clock, somewhere here. See? Not here.
Right.
Okay, if you keep it there, so and you come from about 3 o'clock position, you go towards the 10 o'clock. So you go from right to left this way. If you want to go to the pancreatic duct, you go from the left to right. So we are now interested. See, now I'm just going to go this way. See, this is the way I want to go. Okay.
Right. It's important to have the correct angulation, otherwise you tend to get into the pancreatic duct instead of the CPD.
Yeah. See, I'm just kissing guide wire. So main thing is, see, this is the ideal position. See, I got the right angulation, and you see the ampulla. See, you saw that just it went in. Now the $1 million question is, are we in one of the ducts? To know which duct I am in, because I am pretty sure, 99% sure we are in the bile duct, because the direction it took. But there are two other 100% chance. One, I'll aspirate and see whether I am seeing the bile, or the duct we are going to see in the C arm is parallel to the vertebra or across the vertebra. Come back. We are having on this end, I am getting a bile, so I am pretty sure. But the ideal, see, can you focus here? Can you see the bile here? A tinge of bile. Still to be absolutely sure, I want to see radiologically. Yeah, it's actually low-lying cystic duct. You can see separately. There is a slightly dilated system. The common hepatic duct, if you see, the diameter is more or less the size of my scope, more or less. I won't say. The scope size is around 10.2. So it is around 9. Definitely more than 9 mm. So there's definitely CBD. So you have to take the size of your scope in order to measure the thing because of the magnification. So it is quite dilated. Even the cystic duct caliber is quite large. So there is no doubt. And now what you need to do is, now you can see the bile is coming also, as because we are deeply cannulated. I'm just going to see, this is not a clever cut what Olympus is having. So the whole so I have to be very careful.
What are your settings for the cautery?
I am actually using an endo cut by, it's not ERCP, but in ERCP papillotomy, they have a effect 1 setting, they have a cut interval and everything 3 and 3, but here is the same slightly different setting, but usually we have a wattage of around 25 to 30. And you go right up to the summit of that ampulla, the bulging portion, but not go around that first duodenal fold. See, the first duodenal fold is about a centimeter away, but still there is a little bit I can cut there.
Right.
I'm just going to cut a little bit more like that, and I'm going to stop there and see whether you can go in like this. The whole thing can go. And if you want to be absolutely sure, there is one more technique we found very useful, is balloon sphincteroplasty. What's your view on the balloon sphincteroplasty, Jaydeep?
So I think I am not somebody who does ERCPs, but all my patients who I send to the surgical gastroenterologists who do the ERCPs in our system, they do tend to use balloon sphincteroplasty, but not so much as doing a papillotomy with the energy source. More often than not, I think that is what the preference here is.
My dictum is, Jaydeep, anybody who are having a size of a bile duct about 10 mm and more, and moreover you have a stone if you are expecting a slightly bigger, it actually makes the ease of removing the stone much better, because so it is very
Right.
simple technique. It is again wire guided, as you can see. I'm just to go there after a partial, then it goes nicely. You can easily go. You put the balloon,
Yes.
which is about 4 centimeter length, about 3/4 inside, 1/4 outside, like this. And you should see the little
Yes.
bit of,
Yes.
see that is the little bit, you can see the width outside, about a centimeter of the catheter is you are able to see there. And in that position, you ask them to
That's correct.
inflate, and you show the hand. She is having a special inflation Alliance gun. So with that, she is inflating, and this causes quite a uniform distance and dilatation of the sphincter. Hemostatic also. Maintain that for about 30 seconds. There is a pressure transducer there. It will tell me exactly this CRE balloon
Yeah.
at what pressure you get what diameter. Actually, the thing we have, there is actually a small piece of information. This is actually 10, 12, 15. So I'm going to distance it only to 12 mm, not more than that, because you should not overstretch. What is the pressure? 100. Okay, so that means it is around 10. So 10 millimeter. I will go little, just a little fraction.
Yeah. I can
Okay, that's
appreciate
enough. Deflate.
the manometer.
So you can see the whole thing is, sometimes the
Beautiful.
stone literally drops out, as you can see. See,
Yes.
the stone came out. Did you saw the stone?
Yeah.
You saw the
Beautifully,
stone,
beautifully.
Jaydeep?
Yes. I
See,
appreciate
that is
it.
advantage of good.
Beautiful.
This is a Fogarty balloon.
Right.
I'll just go. Guide your look. Inflate. Screen panappa. And you watch the C-arm, and you can see that Fogarty is right just below the common hepatic, just around that, just above the
Yes,
cystic duct.
yes.
I am just sweeping the whole duct. See whether there's
Right.
any other stone. The big balloon came very easily. That means that was the
Yes,
only
yes.
stone causing the obstruction, which we removed. I go one
Yeah.
more time, inflate. And see, it's inflating the balloon at the lower end, inject.
Right.
And I'm doing what we call a balloon occlusion cholangiogram. So the balloon is at the lower
Right.
end. I'm now injecting, filling the whole system. Screen. Shift it to the other side. Inject பண்ணிட்டே இருமா. Screen. It is bound to be some, but it is not filling as quickly as the other, because now the stone is
Yeah.
out, as you can see.
Yes.
But still, yeah. Deflate. Now I'll deflate and then go in further. Easily it
Right.
goes in, and then inflate. 2.5. Screen. See, you can see the same place. I'm just taking it out. You can see very easily as it went. It came very, very easily, and you can
Yes,
see most
yes.
screen. Most of the contrast would have come up, but for the contrast within the biliary system is because of the patient's position. So
Position,
once the
yes.
patient's
So the
position is
defined
okay, it will
control.
drain freely. So I'm not worried about
Right.
that. So,
Absolutely.
and also there is no undue bleeding, as you also agree with me. I'm going to just do away without putting a stent for this patient and
Absolutely.
leave her. And also we have a drain inside in case if she needs also. So thank you for being with us.
The situation that you are in your own OR,
Yeah.
and you have the setup where you are having the ability of doing ERCP and laparoscopic surgery together.
Yes.
Wouldn't you want your ports to be in place and not come out with the ports completely? Because sometimes you may require some laparoscopic manipulation in case of some difficulty encountered in trying to guide a stone down.
Yeah. See, that is a good thought. I mean, we can, that is the only way we can do it. Intraoperative ERCP. See, I told you, there is a situation wherein I think it is going to be a little technically difficult. Cystic duct cannulation, put the cannula there, then I take the scope, do the procedure, or my
Right.
colleague who is another surgeon can do. Then we can continue with the lap chole. There is a truly laparoscopic round-do procedure.
Rendezvous, that's
Yeah.
the rendezvous procedure, right?
Yeah.
So because I was trained in that technique by a surgeon called Duluc from Bordeaux in France.
Okay.
And that is what we used to practice. You take a small incision on the cystic duct before performing the cholecystectomy, and pass in a tube and do a cholangiogram from there, and you already get an idea of what you will be expecting if you have to do an ERCP.
Yes.
That many surgeons will be, hopeful that they can start doing this and not lose it to the gastroenterology colleagues.
That is really the reason why I'm pushing this. You ascend on the ladder, starting with the basic endoscopy, colonoscopy, start doing some banding. Now this is a stage you come, and it is possible for everyone. Don't take a shortcut. Stepwise you can do, but the learning curve is there. But I think 5 years down the line, starting from your endoscopy practice, sometime if you have that aim, I aim, I'm sure you can achieve. Like you and me, you are able to do. I'm sure everybody can do that, Jaydev. Thank you very much.